In May 2023, I was commissioned by the Department of Health in Northern Ireland to conduct an independent report. It was in response to concerns about safety of midwifery services specifically in Northern Ireland. A coroner's report following the death of a baby raised specific concerns about care in freestanding midwifery-led units, and there were wider concerns about safety of midwifery and indeed wider maternity services. The report that Sue's just been telling you about was published in October 2024. It still feels very new. We're really just now talking about it and working on disseminating it to all the places that matter. It was immediately positively received by the Government of Northern Ireland, which has committed to implementing the recommendations, which is amazing. And as Sue said a minute ago, it's the first report on maternity services in the UK to examine a whole health system and to specifically use an evidence-informed analysis to identify solutions. So what I'm going to do this evening is tell you about the report and draw out towards the end some of the lessons that might apply more widely across the UK and beyond. Before I get into the details of the report, I just wanted to take a moment to step back and think about the wider context of this work. You will know better than I do the current environment for maternal and newborn care across the UK particularly, more widely as well, but tonight we're really focusing on what's happening across the UK. And it challenges all of us to think hard about what matters for women, for babies, for families. We hear criticism of the maternity services on an almost daily basis. The social, the cultural, the clinical contexts of maternity care, women's views and expectations, and the pressure on the health service and on health service staff, they're all unprecedented. I qualified as a midwife, I hate to tell you, in 1978, haha. That's a long time. I have never seen in that time conditions in the kind of perfect storm they are at the moment. The other thing that we're all experiencing is the public discourse around maternity care, and especially around midwifery, is really negative. But here's some questions for you. What should the care of women, babies, partners, and families be at this most formative of times for babies at their birth, for women as they're going through pregnancy, and for the beginnings of families? Is the current model of care working? Are the very high rates of interventions appropriate? How do we decide what's right and what's wrong in the provision of care and services? In this work, I've had to grapple every day with those essential questions and more. It's been hard. I will tell you that, almost impossibly hard at times. But midwives are working almost impossibly hard every day of their lives at the moment. I know that. And there were wonderful, talented people working with me, women and their families, midwives and interdisciplinary colleagues who all rose to the challenge. They all needed the answer, and never for a single second did any of us think it wasn't worth doing this report and doing it as well as we possibly could. I'm going to take you now, after that little thought about the wider context, I'm going to take you into the context of Northern Ireland. There was a coroner's report, I've just mentioned it. A baby died as a result of shoulder dystocia that happened in a freestanding midwifery-led unit. And the coroner's report required a review that looked at these first two terms of reference. One was a comprehensive review of staff experience and training and policies for freestanding midwifery-led units. And then second to that, we needed guidance to all the trusts regarding the management of raised maternal BMI and shoulder dystocia, those being the issues around this baby's death that the coroner was concerned with. On top of that, the Department of Health added a third term of reference in the recognition that midwifery services don't stand alone and that you cannot look at them in isolation from the wider maternity services. So I was asked to undertake further work to inform a consistent approach to the provision of midwifery services, including integration across the wider maternity services. Now that took us right out into looking at the whole system, right across the whole piece. We reworded that and reworked that a little bit into our overarching aim to identify the key conditions for safe quality midwifery services in all settings in Northern Ireland. With this, if you like, mission statement that evidence-informed, equitable, safe, respectful and compassionate midwifery care should be available for all women and newborn infants wherever and whenever care takes place. So that was what we were aiming to examine. This is the context into which this work was happening. Northern Ireland has the highest proportion of people living in the most deprived quintile in the UK. So although there is deprivation across the UK now, Northern Ireland has that highest proportion in the most deprived quintile. That is quite a challenge. And of course, poverty has been getting worse and still worsening. And so that is definitely a critical context for this work. Northern Ireland has a legacy of political instability. Indeed, at the point at which I started this work, there was no government in place. It had been running for about 2 years without a government. And that had an adverse impact on the funding of public services. The government came into place a few months after I started the work, and since then they have been very supportive. There's been no maternity strategy in place since 2018, in large part because of the lack of government, but also the lack of funding to support that work. Like everywhere across the UK and indeed other countries, the complexity of maternity care is affected by increasing rates of poverty and rates of disease such as diabetes and obesity. Long-standing workforce shortages, especially midwives, will be news to nobody out there tonight, I imagine, but very acute in Northern Ireland. There's about 20,000 babies born annually, almost all in hospitals across the 5 health and social care trusts. There are 5 small alongside midwifery units. There were 3 freestanding midwifery units, but they were all closed as a result of the concern about their safety. Partly they closed in COVID and then didn't reopen, if you like, because of concerns about safety. Until this work was finished, that was the agreement. It's important to start any investigation by looking at what's happening to maternal mortality, to stillbirth, neonatal, perinatal mortality. Maternal mortality, as you know, has been ticking up gradually. Now, we do not have maternal mortality figures for the individual countries across the UK because the numbers are thankfully so small that they're not presented in that way. But this is the stillbirth, neonatal and perinatal mortality rates for the UK and for all of the countries. If you just look at Northern Ireland for a moment, what you will see is that those rates are higher than other UK countries. They are all ticking up. And that's one of the problems that we have right across the UK, is the fact that for all of us, the stillbirth, perinatal mortality rates are rising pretty well for the first time in a very long time. Induction of labour rates, again, colleagues in the rest of UK will recognise that these rates have been rising over the years. Here I'm doing it from 2013. The orange bar at the top here is Northern Ireland. The rates are up there. And as a comparison, we've got the dark blue bar in England and the turquoise bar, which is the US, which we have often thought is the benchmark of highly medicalised care. But at the moment, rates of induction are higher. And they look here like they've plateaued out a bit, but they have been rising steadily. These are the data for caesarean birth rates. And what I've got here at the bottom is the OECD average. Now that is the average of countries that are economically similar to the UK. And if you look at the green line here, that is the US. So bunched up here, we have the UK countries, all really, really increasing. There's a dramatic increase from 2014 on up. And only because we've got the 23 data for a further year, it looks as if Northern Ireland is ahead of the pack. But if you look at the year where we have data for everybody in 2022, it's all pretty similar. What we're hearing from individual hospitals now, from Northern Ireland and others, is the rates are heading well on up from that. The rate of increase has not slowed. It's totally unprecedented. We've never seen anything like that. And indeed, the UK is extraordinary in this, in that I believe it's the only country in the world where the rates are as high as this, and there is universal professional midwifery. It's quite a combination. So what did we do in this report when I was asked to do this? The first thing I wanted to do was establish a number of core guiding principles, if you like, for the work. I've put them all out here. I'm not going to talk you through all of them. I just want you to register that we had absolutely grounded in guiding principles with a core focus on the needs and views of all women. And that basically is a human rights approach, looking at equity, leaving nobody behind, all women, newborn infants and families, evidence-based, collaboration and participation, a whole system approach, and noting that safety parameters should include physical, psychological, social and cultural safety. And that should be for women, babies, partners and families, and of course for staff and students as well. We developed a novel methodology. There wasn't really a methodology for conducting a review like this. We had to design it. And I had fantastic support from our expert group in terms of designing this. Now, our expert group, I don't know, some of you may be out there tonight. If so, huge thanks to all of you. It was a group of UK and Canadian researchers, expert practitioners and educators, and service user advocates with extensive experience, and really helped to design this methodology. So it was 6 steps. We clarified all our principles, our approach, our definitions, our methods, and designed it. We established our expert group I've just mentioned, and our advisory group. Again, some of you may be out there tonight who were senior Northern Ireland colleagues right across the disciplines, and of course, service user advocacy input as well. And they met throughout and were fantastically helpful, as well as fantastically challenging. It was not an easy ride, let me tell you, at any point of this. We then examined the evidence with the help of the expert group. We conducted 8 rapid systematic reviews, examined data, looked at information and policy context. Lots of engagement, participation, hundreds of women, partners, staff of all sorts, midwives, students, interdisciplinary colleagues, senior colleagues, policymakers, managers, decision makers of all sorts, and all the organisations involved in maternity care, because of course it's a hugely complex business. You've got the regulators, you've got the Public Health Agency, you've got educators, you've got the university, you've got all sorts of organisations involved in maternity care and the way it works. So that all happened throughout. We wanted to look not only at problems and failure, but also to identify positive service developments, because we wanted to take a strengths-based approach. I don't know how anybody knows how to do the right thing if you don't see the right thing. How do you learn what's right? You can't learn what's right from only looking at what's wrong. And so we wanted to identify positive service developments, which we did across Northern Ireland and the rest of the UK, and one from Spain. We then analysed and synthesised all of that in a structured process I'm about to show you. And out of that, and with continued input and discussion, we evolved the recommendations. I think my point to this method and methodology, and the reason I'm taking time to explain it, is it was novel. It hasn't been done in this way before, and we wanted absolutely everything to be transparent. So when you look at the recommendations, you can see where they come from. They map back to the analysis very directly and in detail. So if you want to know why something's being recommended, you can go back and read the basis for it. We did this systematic analysis using evidence-based concepts. Now that's a great phrase, but what does that mean? What we wanted to do was interrogate what we were finding from the engagement and participation, from the evidence base, from the data, from everything that we were gathering from all of the sources we gathered the information from. And so we set up two sets of concepts. One set of concepts was around quality maternal and newborn care. Anybody who knows the QMNC framework from the Lancet will not be surprised by this. But the other was around how a health system should work. So we went through two sets of questions. And here are the quality maternal and newborn care concepts. We asked these questions of all of the evidence that we gathered from all of those sources. And again, tonight, I don't have time to go into each of them, but are women, babies, and families the focus of care and services? Are they receiving safe quality care across the whole continuum of care? Are they receiving the universal care they need, as well as the additional care they need if they have complexities? Is there a shared culture, shared values and philosophy that strengthens women's own capabilities? So those kinds of questions, we interrogated our findings and addressed and answered each one of those individual questions. Was the answer a no? Was the answer a yes? What was it? And what did the evidence have to say to each of these questions? But of course, care is only one aspect of what's needed to run a healthy maternity service. You need the whole system to work. And so we did a systematic review. The wonderful Christina Mattison led that from Ontario. And we came out with the key concepts for running a quality, safe health system for women and babies. And these were then the concepts that we then interrogated again. And again, you can read those yourselves: political will and policy direction for a quality service, consistent standards, policy and practice based on all the best evidence. One of those concepts is universal whole continuum knowledgeable skilled midwifery, and it's right in there at the heart of the health system concepts, and I'm coming back to that. There's then all the governance issues, capacity building for research, and education, training and staff development. We weren't only looking at practice, because of course practice has to be grounded in evidence, in policy, in education, in training. So we looked at all of those things. That really is why the report is quite so long. The one thing everybody says to me when they say, oh, we've seen your report out, it's very long, isn't it? Yes, it is. And it is very deliberate because we had to do all of that work. What did we find? So I'm going to summarize on a graph for you at the moment, and I'm going to kind of unpick it backwards, and you'll see why. There's a lot of there's a lot to read in this report about what we found, but I've just summarized here because what we were aiming for was to identify the root causes of the problems, not only the description of what was happening, but what was underlying it. And that's why I'm unpicking this backwards, because first of all, I'll tell you what was happening. For women, babies, and families, we found things that would not surprise you if you've read the other reports from England. We found serious deficits in care. We found trauma and distress, physical and psychological damage for women and babies. We found 3 particular deficits in care. One was for women in pregnancy, where they were getting very little care, support, information, discussion about evidence, about options, about what they wanted, about their own particular care. The second was in late pregnancy into early labour around induction. And it was a real problem for women. It was a real problem for the service. The numbers of women coming in for induction were very high, and the service couldn't meet their needs. And women were sometimes waiting for days after the first part of their induction before they got on through and into labour. Some of them were being sent home. Very stressful, very difficult for women and their families. And the third serious deficit in care was in postnatal care. Now, partly that was because the postnatal staff kept getting pulled through to labour ward, but partly it was also because the caesarean section rate was so high, with 40% of women on the postnatal ward being immediately post-major surgery. Very, very difficult indeed, and it's not something that's been discussed nearly enough, with the potential for both physical and psychological problem, as well as looking after the baby's health and well-being. A lack of equity I have here, persistent inequalities, a long-term impact on early years, women's health and well-being, and population health and well-being. So that's a very, very brief look at the issues. There were many more issues than that. But what was going on for the staff? What the staff were reporting, and this was midwives, this was interdisciplinary colleagues of all sorts, and students, all describe very similar things from different perspectives. That the whole ethos of maternity care had turned into a task focus, very limited time for support of women, giving information, and prevention really neglected. Lack of personalised care. The model of care, which was this task focus, high intervention model, had developed piecemeal and actually didn't really relate to the guidance once you started comparing it to NICE guidance. Ineffective response to escalation and to adverse incidents. Often that was because people were already too busy and too stressed. A lack of interdisciplinary discussion, planning and review. So there wasn't really a strategic overview of what was happening. Staff and student stress, distress, and of course retention problems, as well as absentee problems. So why was that happening? Where did that come from? Once you tracked it back, it came from a number of factors that related to how the system was working. Right through the system, we were finding that maternity was not a priority. It was a small specialty, so people said, compared to some of the bigger areas of healthcare. I'm never quite sure how maternity is seen as a small area. given that women and babies and families and all of that are all needing care. Fragmentation of care provision, real lack of continuity. And I have to say, Northern Ireland has tried really hard to bring in continuity of midwifery care. It's a real policy agenda, but still care was very fragmented. Fragmentation of accountability. It was just very striking that it was very hard throughout the maternal journey to find who was accountable for what. Long-term workforce shortages, especially of midwives, silo working for professions, silo working for settings. And in relation to the coroner's report I mentioned earlier, that hospital, different bits of the hospital, out of hospital, if the midwifery units, and home, very separate from each other, not joined up. Funding constraints, of course, safety focused on hospital and on birth, and that's about what I've just said. There wasn't really any safety work going on much in postnatal, and there wasn't much safety work, if any, going on in the community units or related to home birth. Limited monitoring and evaluation and availability of data. A culture of fear and blame that was mentioned by women, by all staff, by students. No consistent strategic direction, limited CPD, and that CPD was not related to what the staff needed to know. No opportunity for participation of women, families and staff in the design and delivery of services, and a disregard of the long-term impact. So if you then look at that forward, you can kind of see where we need to intervene. We don't need to really pause to think these are the things that need to be tackling the health system issues so that life becomes better for the staff who really, the vast majority of whom were absolutely dedicated and wanted to do the right thing. And they just needed the conditions in which to do it. And that then would result in much, much better care and outcomes for women. We analysed the positive services. We had 15 examples from across Northern Ireland, the rest of the UK, and one from Spain. And we looked at what was making them work. And we took out these characteristics. And it was the combination of partnership working with women and families, a shared focus, values, philosophy, vision, and culture, ensuring evidence-based care and standards, enabling and supporting midwifery care and services, and positive interdisciplinary team working and education at all levels of the system. So that brings us through to what we then said. What should services look like? Now, I'm not going to give you the absolute breakdown here on midwifery units and home births in answer to the coroner's question, but also to say, what should safe quality care look like out of hospital? We've been very detailed about that, and you can read that in the report. It's incredibly important. What I do want to draw your attention to is what we then outlined as the key conditions for maternity and newborn care in all settings, every setting in which women and babies need care across their whole maternity journey. So we have summarized this in this diagram here, which is, if you like, a sister diagram to the Quality Maternal Newborn Care Framework from the Lancet. This is a quality maternal and newborn health system, and we've brought 7 key conditions. The first one of which is the focus on women, babies, families, and communities at every point in whatever part of the system is working. Starting up here at 12 o'clock at the top, you've got meaningful participation. Women, babies, families, communities, and staff. Now that means they have to be embedded into decision-making forums throughout so that their views are actually making a difference. Integrating standards, services, and education across the continuum of care, the whole continuum, pregnancy right through to postnatal, all disciplines and settings. An enabling environment and psychological safety for all staff and students with respect and shared values. Down here is one that surprises some people, but I don't guess will surprise most of you out there. Fundamental to this health system working, the quality maternal and newborn health system working, is whole system support for universal, accountable, quality midwifery. Of course, interdisciplinary colleagues matter hugely. Every day they matter to women and babies. But if you don't have midwifery that's safe and available and accessible for women, things fall apart. Midwives are the glue in the system. They are the people who are there for prevention. They're there for support. They're there for right through the whole journey for both the mother and the baby. And without them, if you weaken that, the system is weakened. Around here, we've got structures, processes, and resources for evidence-informed planning, monitoring, governance, and commissioning. Absolutely critical to get that aligned with the needs of the system. And then, of course, political will, evidence-informed policy directions for safe, quality, equitable, sustainable system. That we're saying should be what a system looks like wherever it occurs. Now, that's a system level view. This is the same concept, but from the woman's point of view. And so it's about the whole maternity journey. Round the outside, you've got those essential conditions I just showed you. But this is the woman who ends up with her baby. We hope, of course, there will be some women who encounter loss in that. And they, of course, are critically important through this whole journey as well. But they start in the family and community. They go through early pregnancy, labor and birth, through their whole journey, postpartum, back into the arms of their family and community. And this is where the health service has to get these key conditions absolutely right with these qualities. Now, these qualities were absolutely brought to us by women and staff themselves. The service has to be imbued with respect, kindness, trust, relationship, continuity, prevention, support, and evidence. Women wanted evidence as well as staff wanting evidence. They wanted to know why they were being advised to have an induction, to have a section, they wanted to know why, they wanted to understand. So I know I've only got a couple of minutes left, but what I wanted to say is we then have moved from evidence to action. And we're talking now about transforming maternity and newborn care and services. We're not talking about individual recommendations. We're talking about a transformative implementation plan. There were 32 recommendations. I've summarized here what we're asking for, 3 essential components. To get safe, equitable, quality care and services, we need a reconfigured relationship with women, families, and communities. This is not lip service. This is actually about women and service user advocates being right in the design, the planning, and the assessment, the monitoring of services. Absolutely there. And when women are being cared for individually, that they are treated in a different way with respect for their own situation and personalized care, if you like, but it's much more than that as well. Over here, we have the enabling environment for all staff and students in all settings, and that brings in education, support, a shift in culture. And over here, we have better informed, better implemented commissioning and governance, where the commissioning actually fits the needs of the service and the governance fits the needs of the service. Okay, now I know it's late at night for some of you, and I know this is a bit of a blinder. Don't try and read the small print. This is the summary of the detailed recommendations for system transformation. I wanted this to be a midwife's wheel. So if you think it looks a bit familiar, that's because it's meant to. What we've got around the outside here are the components of the changes that matter. Regional strategic developments, they need to be consistent. They need to be grounded in evidence. They need to be collaborative across the 5 trusts so that women are getting consistent care everywhere. Round here in the orange bit, we've got safe quality care and services in all settings. So that's about home birth, that's about midwifery-led units, and that's that we're now calling community midwifery units, and that's about hospital. and then building for the future, capacity building. So you can read in the report what each of those is, but those are the sort of chunks that we went into. I don't need to tell you why this matters. This matters for every single woman, every baby, every partner, every family. Nobody is untouched by maternity care. And for the baby, it's the beginning of a whole new human being. It is the beginning, if you like, of the population. Over time, every person goes through this system. And that's there for short, medium, and long-term impact. And we forget that at our peril, physical and psychological and emotional. What's happening next in Northern Ireland is the recommendations have been accepted by the Department of Health, with 2 caveats around timing for 2 recommendations. The overall aim is the development of a regional maternity improvement plan as a blueprint for the maternity and neonatal services. Collaborative working has already started. They jumped straight in to doing that. I'm hoping that you're going to talk to me about the learning for the rest of the UK, about what in this is resonating with the other UK countries, because I think it's really important that lessons are learned for safe quality care for everybody right across the maternity journey. I've spent my career working in England and in Scotland, as well as this work in Northern Ireland. I haven't had the pleasure of working in Wales, but I know from Welsh colleagues that there are real resonances there. And I believe there are also resonances out across the world. I've done enough work internationally to absolutely recognize those. I'm about to show you very quickly a couple of slides of some of the lessons that I think are there for other countries. But while I'm doing that, I'd like you to be thinking of the comments you want to send in, because I would like to hear what you think the resonances are for the rest of the UK. I'm just going to remind you that that is actually, if you like, what we would be aiming for in any health system, is that journey for women right across their continuum. Loads of words on here. Take a photograph of this, do what you like with it. But these, for me, are examples of learning for the rest of the UK. And this first slide is about what are the lessons for reviewing care and services. I'm not going to pause on it, so do take a photograph and have a think about it later. But I think there are important issues here for how one reviews care and services if you're thinking of that in your own area or if there's reviews going on in other areas. And then I've got some examples that are about lessons for implementing change into practice that we're going to provide all women, all babies with the best, safest quality care at all times. These are some of the issues that I think need to be thought about everywhere. So I'll come back to these 2 slides, but I wanted to say a huge thank you to absolutely everybody who participated in this, and particularly the women who found it very difficult to do. We worked really hard not to re-traumatize women when we spoke to them in this, but there were women who'd had very difficult experience who wanted no one else ever to encounter that experience again. And I just want to acknowledge and thank them for that. We also had women who had great joyous experiences, and they wanted every woman and every family to have the experience they had, and we heard their voices too. Thank you very much for listening to me tonight. I really appreciate it.